Hi, everybody. I'm Seth Truger, Digital Media Editor for JAMA Network Open.
And I'm Mike Berkowitz. I'm Electronic Editor for JAMA in the JAMA Network.
So welcome to this week's episode of JAMA Network Open Live. We're going to talk about a couple papers from this week's release from JAMA Network Open. If you're following along live, please be sure to send us your questions or comments through our social channels. Either respond to the Facebook post or reply to us on Twitter at JAMA Network Open.
And if you're watching us now or after we're live, make sure to follow us at facebook.com/JAMA Network Open or our handle on Twitter, JAMA Network Open.
Right. So first paper we're going to talk about, the ultra-restrictive opioid prescription protocol for pain management after gynecologic and abdominal surgery by Mark et al.
So those are big words,
Yes.
Seth. What exactly happened? What did the researchers try to do in this paper?
So these were researchers from one institution in Buffalo. Patients who are routinely prescribed opioids don't use their pills, so that's just more pills that are out there that aren't necessarily helping anybody with pain, but have potential for either abuse or addiction.
So this is one medical center's, one division's attempt to see whether they can get a handle on the number of pills that are leaving the institution.
Right, exactly. So what they did is they started, at one point in time, they started a protocol where they just routinely didn't give any of the minimally invasive cases or the ambulatory cases any opioids unless the patient had required 5 doses or more while they were in the hospital. And for patients who are getting full laparotomies, they were giving them a 3-day supply.
I see. So I'm a patient, and we hear a lot from patients that I'm in pain and you're not managing my pain. So how do we know that the doctors weren't trying to solve one problem but making patients feel worse in the process?
Right. So that's one thing these authors did a really good job of accounting for is they really, what I think from reading the study, did a good job of making sure they were controlling patients' pain. Everybody was getting prescribed round-the-clock NSAIDs and acetaminophen. Everybody who got 5 doses of opioids in the hospital while they were admitted after their case did get a 3-day supply or 12 pills of either oxycodone or Absolutely.
Wonderful. So what was the outcome of this QI effort?
Well, if you look at figure 2A, you can see that more than anything else, were about the same in both groups. The complication rates were about the same, which is good because it shows they're roughly the same amount of acuity or illness. It's not like all the patients who had lots of post-op pain were only in one group and not the other. But overall, they did about the same in both groups.
So they were able, is it true they were able to cut down on the number of opioids prescribed and had fewer or the same or no change in patient complaints or pain needs?
That's what it looks like, yes.
Well, that's outstanding. Now, one of the things that I wonder about in these kinds of studies is what's known as the Hawthorne Effect, which is when you kind of set up an examination or an evaluation or an investigation and you're actually looking at something really, really intently, the care differs from how it usually kind of carries out, right? So that they may have been so attentive to pain through non-opioid interventions that they ended up with a result in this investigation and in this QI effort that looked really favorable, but in an ordinary healthcare setting, that might not be the case. What do you think about that?
Right. So that's certainly something that potentially could have happened in the study. I'd love to see some follow-up data down the road to see if their numbers do creep back up or if they stay strict and make sure that they're also attending to the patient's pain. What I've noticed in my practice is that there's been a lot more attention to opioid prescribing. There's been a lot more attention to just how much we casually give to patients without necessarily thinking about how much they need or how much will go unused. We haven't had anything formal like this in my institution, but I can tell you the numbers have gone down. We basically just informally every quarter or so get some anonymous data from our comparing us to our peers in our department about how much we prescribe. And you know, it's kind of nice to say, hey, I'm not an outlier. I'm kind of in the middle somewhere. I'm in a nice little plateau. But the numbers have definitely gone down in the 2 years or so we've been doing this.
I think that's a good thing. How does this effort that's really structured and almost an algorithmic approach to opioid prescribing differ from the way we typically, or at least I used to do it in the ED, which is here's 2 days supply, here's 6 pills, and you're done. So there's very minimal excess supply available for diversion or misuse.
Right. So in their protocol here in the study, it was pretty regimented. You know, they were giving 12 pills at a time or 24 pills at a time, as well as giving the baseline NSAIDs and acetaminophen, and then giving patients the opportunity to get refills when they need it, as well as see clinicians if they were having recurrent symptoms. Most of us don't live in a place or don't work in a place where it's this structured, so a lot of us are just kind of like, all right, I mean, I've probably decreased the kind of default prescription that I give in, where I think I used to give probably 15 or 20 pills most of the time, and now I usually give 8 to 12 pills, but I still kind of modulate it based on how much I anticipate the patient's going to need.
Good. And if you're watching and you have a unique way that you guys approach this in your medical centers or practices or clinics, please leave notes in the comments so that we can kind of share it with everybody and incorporate it into our understanding of this study.
Great.
Great.
Okay.
What do you have up next?
Okay. Next paper we have is Patient Attitudes Towards Individualized Recommendations to Stop Low-Value Colorectal Cancer Screening by Piper and colleagues.
Okay, so individualized recommendations to stop low-value colorectal screening. Let's start with the definition of low-value CRC screening. What is that?
So basically patients who are either too old or low life expectancy to really benefit from getting colon cancer screening. Because essentially, what's the point of getting diagnosed with colon cancer if you're not going to be able to survive the treatment for it, if there really aren't going to be any therapeutic options, or if the likelihood that that's going to be the thing that kills you or affects your life is really going to be, you know, non-trivial.
Right, and JAMA published the U.S. Preventive Services Task Force recommendation statement on colorectal cancer screening. So just do an easy search for colorectal cancer screening or Preventive Services Task Force in JAMA. We have the links on our site. And if I remember correctly, and I may not be correct, it's stop at age 75 or consider stopping at age 75 and definitely stop at age 85.
Yep, they actually talk about it in this paper. It's a general colon cancer screening is a Class A USPSTF recommendation. I just like saying USPSTF.
Yes.
But individualizing screening recommendations for older patients does also receive a Class C recommendation.
Okay. And
yep.
Class C is possible harm. Right. Okay.
Yep. So, is it possible harm or you can consider it? I thought D was harm.
I thought A was strong evidence to do it, B was weak evidence to do it, C was weak evidence of harm or mixed evidence of uncertainty, but we should follow up on that. And if you're watching, leave us the comments if you know that grading system better than we do. Yeah,
you know better than I do. I don't do a lot of preventative services in the ED, mostly just tetanus shots.
Right. Okay. So let's go on to this study.
Okay. So this was out of the VA in Ann Arbor.
Right.
They sent a survey.
Some of my friends are there. Hi, guys.
So they sent a survey out to about 1,500 people, veterans in the VA system, so mostly older men. They got about 1,000 responses back, and basically they offered them a theoretical colon cancer risk score or life expectancy screen, as well as a number of other related questions, and then asked them, you know, if this screen said you wouldn't benefit from colon cancer screening, or if this calculator suggested you wouldn't benefit if your life expectancy was low, or if your doctor recommended that you not get colon cancer screening, is this something you would forego? What's interesting is these were all patients who had had their initial colon cancer screening in the first place. So it's already a little bit of a smaller population. It's not just general patients, but it's a small population of people who already had one colonoscopy or other screen.
So they've already had one. And had they moved into their low-value age group or comorbidities, or like, how was the population split?
You know, I don't remember the details. I think some of them had, but I think it was just a bigger group of older patients with who had undergone the screening.
So it's basically a simple question saying, if we determined that it was of low value to you, would you still want us to go ahead with it, right?
Right, exactly. And as you can see in Figure 3, basically
is these recommendations to me seem to be need to be made in the context of a relationship, of an ongoing relationship with ideally a primary care, but any kind of physician. So my reaction to this is I think the question is, if your doctor didn't think screening would be of use based on a calculator, that seems to, I think, trigger this fear of number crunching, like you're treating me like a number, not a patient. And if that recommendation came from a physician to a patient in the context of an ongoing relationship, I imagine there would be greater uptake of that physician's recommendation.
Yep, I would think so as well.
And there were risk factors, right, for either accepting the recommendation to stop or for declining the recommendation to stop. Do you remember what those were?
You are putting me on the spot, and I'm blanking on those right now.
So let me tell you what I remember based on the abstract, that the people were more comfortable with screening cessation if they had a higher trust in their physician, which is the kind of notion that I'm putting forward. Higher perceived health status, which is, I'm imagining I don't need it as much, so I'm pretty healthy. Yeah, I'll stop doing that. I don't want medical interventions anyways because I don't need them regularly, and higher barriers to screening. And I'm not quite sure what those are, but I assume that's I got to travel. It's like a higher hassle for me to do the prep and so on. And factors associated with less comfort with screening cessation was either a sense that the intervention was really, really effective. If I have cancer, that test is going to detect it, and I want to know whether I have cancer. And greater perceived threat of CRC. My uncle died, my father died when he was young. I think I want to know no matter what, even if it's a low value.
Right, and that's also a pretty good patient-oriented outcome or patient perspective, that if a patient's really concerned about colon cancer screening, they might have a lower threshold to want to get the screening, even if on average it's going to be less beneficial to them.
Right, and we know that, and that's really what we talk about when we talk about individualizing patient decision-making. And I think, despite recommendations are never hard and fast rules, and we should be taking into account patients' values. And there would be times, and I suspect you're in this situation too, where if a patient really insisted on something because it was important to them, I would proceed with it even if I had adequately communicated their risk, low risk, and my recommendation, and they wanted it, I might go ahead with something like cancer screening.
Right, exactly. Guidelines are never supposed to replace good clinical judgment. They're supposed to replace bad clinical judgment.
Right, good point. Okay, and let us know how you manage this, if at all, in your patient practice. We want to hear what you guys are doing in your institutions around colorectal cancer screening, opioid prescribing, and maybe the next topic, which we're going to talk about, which is?
All right, so our third paper is the incidence of placebo adverse events in randomized clinical trials of targeted and immunotherapy cancer drugs in the adjuvant setting, a systematic review and meta-analysis by Chacon and colleagues. And apologies if I mispronounced the name.
Okay, so that's placebo adverse effects in trials of targeted and immunotherapy cancer drugs. So that's a hot topic. This is a bit of a methodologic paper, I think. Tell us what this is about.
So basically what they're looking at here is the question of whether patients who are in clinical trials for cancer drugs are having adverse events on their own, or are they only related to what's in the treatment arm? And basically, are we doing apples to apples comparisons when we're comparing for new cancer drugs like targeted immunotherapy?
Okay, and go on. Why don't you tell me, and I'll ask my questions later.
Sure.
A little more information.
So they did a systematic review of phase 3 RCTs, where they're trying to see if targeted immunotherapy cancer drugs work. These are fancy drugs like tyrosine kinase inhibitors that are well above my pay grade in the ED. And they basically looked for patients who were in a placebo group who didn't get any other treatments during the study, if they were also getting adverse events. And they looked at what are called, grade 3 or grade 4 adverse events, which I had to look up. And these were pretty serious. And this is one of those things that's actually pretty intuitive, where lots of patients in trials are going to have mild adverse events, headaches, nausea, things like that. Most of these get graded according to this, I don't know, this thing I Googled.
There's a standard scale, particularly in FDA-regulated kinds of trials, pre-approval trials.
And it actually seems, from the little bit I've looked at it, pretty reasonable. Where basically a lot of these are these things that are affecting ADLs? Are these things that are really causing symptoms that impact patients' abilities to live their lives? Not some nausea, but enough nausea to need to come in and get rehydrated or get therapy, or blood pressure that's requiring more than one drug for them to be on for the duration of their blood pressure being up.
Okay, so they're looking at the incidence of those grade 3 and 4 adverse events in patients in these trials with cancers getting the control arm.
Right, exactly.
Okay.
And they found their rates were pretty high. It was 18% of patients. I mean, these are patients who are in cancer clinical trials, and they're adjuvant studies, they're adjuvant treatments, so they're patients who've already gotten some sort of primary treatment already. So these are patients with pretty serious cancer, and this basically helps us see how many people are having bad symptoms in the first place, regardless of whether or not they're getting this investigational experimental drug.
Okay. So a few comments, and let me know what you think. First off, I think this was 10 trials, if I understand correctly, and it was really 3 or 4 different kinds of cancer. It was dominated by melanoma and non-small cell lung cancer, with 1 GIST and 1 other renal cell cancer, I think. And they all had surgery. This is adjuvant targeted or immunotherapy. So they all had resections, right?
Yep, it was melanoma, lung cancer, GIST, and renal cell carcinoma.
So what I'm kind of unclear on, and you may not know either, is the timing of these adverse events following their surgical intervention, whether they're still post-op and getting this, because you would think that a complete placebo or control arm patient might be likely to develop some version of symptoms, and whether it's attributable to the drug or to some placebo sensation or to the surgery is unclear.
Yeah, so they're not immediately post-op. They're in general, I think they were a few months out, and on average, these patients were getting between, I think it was most of the patients in the studies were getting the placebo for about 10 to 15 months around the time that they were getting these symptoms.
Okay, and the other thing that I'm not clear on is typically in these kinds of trials, they're comparing adverse events in the active intervention and the control arm. And this seems like a single-arm study. It's basically a case series of these patients. It's really a meta-analysis because they're gathering up these previously done RCTs. But I didn't understand why they didn't look at the differences in these same grade 3 and 4 AEs between the 2 arms to see really to characterize still what their research question, how many are happening in the placebo group or the control arm, but what the difference is between the 2 groups.
Yeah, they do show that a little bit in Figure 2, which shows a forest plot of where the patients are having symptoms. I think what they're looking for here, as you said, this is mostly a method study, is what's kind of the base rate of adverse event symptoms that patients are getting, regardless of whether or not they're getting the new drug. And it was kind of shockingly high at 18%. That's basically 1 in 5 patients were getting pretty serious symptoms. Again, it was blood pressure requiring more than 1 drug or more intensive therapy than previously. The fatigue, the grade 3 fatigue is severe fatigue interfering with ADLs, which is pretty serious stuff. And the other most prevalent one was diarrhea. I don't want to get into the quantitative ways they went into that, because that's a little bit beyond our public scope. But again, it's interfering with ADLs, severe increased ostomy output, pretty bad stuff.
Okay, a couple other questions. They talk about placebo. Were people getting placebo, that is kind of an IV saline injection is the kind of the classic placebo, or were they getting nothing? Do we know?
These patients, I believe, were all getting either oral or IV placebos.
Okay,
so some of these might actually have been complications from an injection.
Right.
Seems unlikely to me based on my experience with this, but it's certainly possible.
Okay. And then my other comment is really kind of technical, which is that placebo really means something that's given to please the patient, which may have a favorable effect. What they're really looking at is nocebo effects. They're giving an inactive or inert substance and they're having an adverse event. That's a nocebo effect rather than placebo, but that's just kind of playing with words for purposes of interest.
Yeah, but again, these patients were getting these placebos in the context of the clinical trial, and these were all double-blinded trials, so the patients didn't know whether they were getting a placebo, a nocebo, or the adjuvant therapy, and the physicians who were treating them didn't know either.
So my sense is that the implications of this are for kind of clinical trial study design in terms of kind of calculating sample sizes and the kinds of adverse events in future interventional trials that could qualify a drug as being too toxic or kind of symptoms leading to withdrawal rather than clinical implications, right?
Exactly. It's also just kind of good to know how many symptoms patients are having when they're in these clinical trials, regardless of whether or not they're getting the investigational therapy.
Great. And you know what? I have some great news for you. We have our first question of the session. And I think this relates to the low-value colorectal screening. We have the question, do you think that there would be the same attitudes for prostate cancer screening?
That's a really good question. Prostate cancer screening is a lot more mixed. in fact, I believe prostate screening isn't even USPSTF recommended anymore.
Well, it was a D recommendation. There was an active recommendation not to screen patients, and that moved to individualize your decision making with patients. There is likely to be more harm than benefit, but the physician and his or her patient should make the decision together based on values and risks and things of that sort.
Yeah, so I think I would say when it comes to cancer screening, colon cancer screening has been pretty successful in a lot of ways. Our messaging has been good. We've been good at encouraging patients to get it. We've been good at getting insurance coverage for it and that sort of thing. I imagine with prostate cancer screening, the balance is probably off a little bit, and it's probably the attitudes of getting patients to forego low-value screening is probably easier. Also, I think there's, both of these have kind of a bit of a yuck factor for lay people, and I think prostate cancer screening is probably a little bit more of something that patients, a lot of guys know they don't want.
I mean, I would say that was the case when we were screening through digital rectal exam. That's less the case when we're doing PSA and other kinds of biochemical measures. There's less of a yuck factor because it's just another blood test. From my perspective, if really the question is, do you think the same attitudes are in place for prostate cancer screening? That's a study. Anybody who wants to take that up. But I think the same factors are in place. If I have an uncle or a father who developed it and I witnessed their illness, I'm going to want to know whether I have prostate cancer, whether or not it's low value for me. And if I have an ongoing relationship with a physician and he or she recommends for or against it, I'm going to probably follow their recommendations. I think those risk factors, for lack of a better phrase, in the study that we described are probably in place just the same, certainly for veterans, if not for a broader population in terms of prostate screening cancer recommendations. Although the task force recommendation, as we said, starts at a different place, which is discuss it, but the patient should know that there's more evidence of harm than benefit.
Absolutely.
Okay, I think that's a wrap for today.
Yeah, I think that about covers it. Be sure to go to JAMANetworkOpen.com to read these studies and the rest from this week's release, and be sure to follow us on Facebook, Twitter, and LinkedIn at JAMA Network Open.
Okay.